Dear chair people, dear audience, thank you for inviting me. I will continue with the same registry as Dr. Špinarova before me, called FAR NHL, the registry of chronic heart failure with stable patients, and I will focus on NGAL and maybe a head score as well. From the whole group of patients, 1,100, we excluded patients without available follow-up data and available biomarker levels, and gets to the final count of 547 patients. We've set the primary endpoint, which was combined with all-cause death, left ventricle assist device implantation or autotopic heart transplant, and it was present in 74 patients. That means 13.5%. The death as itself was present in 11%, autotopic heart transplant or LVAD implantation in 2.6%. As we know, neutrophil gelatinase-associated lipocalin, or in short NGAL, is 25 kilodalton epithelial monomeric protein bound to neutrophil gelatinase, and its expression is upregulated in acute kidney injury or many types of inflammation or renal or myocardial ischemia or infection. And NGAL predicts mortality and acts as an overall marker for severity of cardiovascular diseases. Here we can see area under receiver operating characteristic curve for NGAL. It was only 0.64 with low sensitivity and higher specificity. We get cutoff for this value as 90 nanograms per milliliter, and we can see here the survival of NGAL or of patients with higher NGAL than cutoff value or lower. The difference is here 20% between those two groups. Then I want to show you the head score. It was set as the score for acute heart failure patients, and each letter of the name AHEAD means one comorbidity, so it's a comorbidity score, and it reflects the prognosis of acute heart failure patients. A stands for atrial fibrillation, H like hemoglobin, for female less than 150, for male 130 grams per liter. Then E elderly, upper than 70 years, A abnormal renal function with creatinine more than 130, and diabetes mellitus as well present. As I've said, it was acute heart failure comorbidity score, but we then transfer it and try to use it in chronic heart failure as well, and these are the results. Head score 0 or 1 point, the best survival 89%, patients without primary endpoints after 2 years. Then 2 or 3 points, 82%, and the most severe patients with 4 and 5 points, only 63%, even in pairwise comparison. We can see that the distribution of NGAL values are strongly associated with a head score. A head score is down 0, 1, 2, 3, 4, 5, and 6, 5. And we can see that the NGAL levels grows when the head score grows as well. From 43 till ahead 4 and 5 till NGAL level 128. And here is a table of influence of ahead comorbidities on NGAL levels. We know that NGAL is its levels are very influenced by these comorbidities that are present in a head score. That means atrial fibrillation, the difference of median of NGAL levels is huge, 13 nanograms per milliliter, or in diabetes, if it is present or not, it's 6 nanograms per milliliter in NGAL. And as well, it acts like that the level of hemoglobin H or NGAL is mostly renal biomarker, so we can see the huge difference in renal functions. So let me conclude this presentation in stable chronic heart failure registry FAR NHL from Czech Republic. NGAL level is strongly associated with presence of comorbidities. AHEAD and NGAL themselves can predict occurrence events in stable chronic heart failure. And serum NGAL level is significantly higher when AHEAD score comorbidities are present, like atrial fibrillation, low hemoglobin, elderly, abnormal renal function, and diabetes mellitus. Thank you for your attention.
Thank you. And now the presentation is open for any questions. Okay. And I wonder, you showed that the HAD score is dependent on some factors that are it is possible to be modified. For instance, you can control the diabetes, or also you can increase hemoglobin. It's just a curiosity. In the 2-year follow-up, do you believe that modifying the score, because probably taking care of the patient, some of these factors can change, you will modify also the prognosis of the patients and the correlation with your biomarker?
Well, I think so, that modifying the stress factors or the factors that influencing the disease is very important. So we need to treat the patient well and titrate the medication to eliminate or lower the comorbidities as much as possible.
Thank you. Just one point, and I give the speech to Lenka Spiranova, but I have to remember you that at 1 p.m., exactly 1 p.m., we will have the pleasure to have the headmaster of our university, Professor Della Rocca, that is also the dean of the organization of the different schools of specialization in Italy. So I ask you kindly to be present at 1 o'clock precisely in the room, because he has just a short time that he wants to dedicate to us. So after this little announcement, Lenka, it's up to you.